But first, I want to thank the Rare Disease Caucus and the Rare Disease Legislative Advocates for the opportunity to speak today about one of the most successful public health programs of our time, newborn screening. My fellow presenters will be speaking a bit more about the latest and greatest in genetic testing for rare disorders, but I get to kick things off by talking about a program to screen for rare disorders that has been in existence for 50 years. So we'll get right to it. Each year, there are almost 4 million babies born in the U.S. Nearly every one of these infants will be screened for heritable conditions that, if diagnosed and treated early, can prevent death or permanent disability. Newborn screening saves or improves the lives of approximately 12,000 infants each year. Often, people think of newborn screening as just a blood test, but it's much more than that. It's a complex public health system involving numerous moving parts. To keep it simple, I'll outline how newborn screening works for a baby born with a rare disorder. Within 24 to 48 hours after birth, the baby's heel is pricked, and that blood from that prick is transferred to a piece of special filter paper. That filter paper is then transferred via mail or courier to the state's designated laboratory, where the lab will run an array of tests to determine if the baby has a condition for which it's one of the many conditions for which it's being screened. When the lab flags that an infant has a positive test, an employee will immediately contact that baby's pediatrician to begin the next steps in the process, which include confirmatory diagnostic testing and the immediate initiation of appropriate treatment. Babies are also given a hearing test and screened for congenital heart defects as part of newborn screening. For the sake of clarity, I just want to quickly note that the vast majority of newborn screening tests are not the genetic tests that you'll hear my fellow presenters talk about today. They are, in fact, biochemical tests that detect for the byproduct of a genetic condition, not the gene actually causing the issue. There are some newer newborn screening tests that rely on genetic testing, but that's the exception rather than the norm. There's ongoing NIH-funded research on the benefits and challenges of incorporating genetic screening into newborn screening. In the United States, newborn screening is a federal-state collaboration. Each state or territory operates its own newborn screening program. The states operate their own labs, they raise revenue to run the tests, they employ staff to follow up with pediatricians and track the long-term care of infants, and they also decide which conditions they will screen for. While newborn screening programs are run by the states and territories, there is an important role for the federal government to play in helping states improve program quality, share best practices, and conduct exciting research to advance newborn screening. That is just what the federal government does through programs at the National Institutes of Health, the Centers for Disease Control and Prevention, and the Health Resources and Services Administration. NIH funds research to advance the science of newborn screening. As I mentioned earlier, NIH is funding studies to examine the promise and pitfalls of incorporating genetic screening into newborn screening. It also supports research into new diagnostic tests for rare disorders and funds what are known as pilot studies, where states implement screening for a new condition. There's no specific line item in the NIH budget for newborn screening, but most of its activities are funded by the National Institute of Child Health and Development, which received $1.38 billion for all activities in fiscal year 2017. CDC has a long-standing and vital role in supporting state newborn screening programs. The CDC enables states to perform quality assurance testing, ensuring that state lab equipment and tools are identifying all infants for which, with a condition for which they are being screened. It also provides technical assistance to labs to develop new screening tests and identify solutions to problems that they're experiencing. The CDC is the leading expert in newborn screening laboratory processes, providing support to every state in 78 countries around the world. CDC's newborn screening work was funded at almost $10 million in fiscal year 2017. While NIH is responsible for research and CDC supports state labs, HRSA is responsible for bringing best practices and improving the quality of newborn screening programs across the nation. HRSA also leads on efforts to educate providers and the public about newborn screening. HRSA's newborn screening activities were funded at almost $14 million in fiscal year 2017. Probably HRSA's best known activities, at least for us geeks in the newborn screening policy world, is that HRSA supports the Federal Advisory Committee on Heritable Disorders in newborns and children. This is a committee of experts tasked with providing advice to the Secretary of Health and Human Service on newborn screening-related issues. The recommendations that the advisory committee is probably best known for is the Recommended Uniform Screening Panel, also known as the RESP. This is the list of conditions that HHS recommends that states include on their newborn screening panels. I should have advanced the slide, I apologize. A condition is eligible for the RESP if it can be identified within 24 to 48 hours after birth. There's a test available to detect it, and the early detection and timely treatment offer a proven benefit. Currently, there are 34 conditions on the RESP. A quick note on the history of the RESP, which I think demonstrates how important federal leadership is to the newborn screening process. Prior to the RESP, there was wide variation in the number across states in the number of conditions screened. This map from 2004 shows that many states were screening for 5 or fewer conditions. In 2002, HRSA commissioned the American College of Medical Genetics and Genomics to develop the Uniform Screening Panel. In 2005, ACMG recommended its final report calling for the screening of 29 core conditions, which the advisory committee then adopted. After that, the March of Dimes, in partnership with many other stakeholders, embarked on a nationwide advocacy campaign to get states to adopt screening for all 29 core conditions. In just 4 short years, all but 4 states were screening for 21 conditions, and 25 states were screening for all 29 conditions. So where do we stand now? The latest map from our partners at the Association of Public Health Laboratories show that all but 2 states are screening for all 34 conditions, or at least 29 conditions, and most states are working toward implementing screening for all 34 conditions on their RESP. So you can see how the federal government's setting a floor, a recommended floor for uniform screening, caused all states to rise up and meet the challenge posed by the federal government. So the next question is, what's next for newborn screening? We must increase or maintain funding for the federal initiatives to support state newborn screening programs. Alarmingly, the president's fiscal year 28 budget eliminated funding for programs at HRSA and slashed funding for NIH. We are grateful that both the House and Senate Labor HHS appropriations bills include level funding for programs at CDC and HRSA and an increase for NIH overall. This funding is so important to states, especially given that 3 new disorders have been added to the RESP in the past 2 years, including XALD, which we heard about earlier. And there are currently new conditions under review at the advisory committee. We hope that Congress will maintain its commitment to newborn screening programs at NIH, CDC, and HRSA in the final fiscal year 18 appropriations package. Additionally, all of these programs are authorized by the Newborn Screening Saves Lives Act, and advocates will be looking toward reauthorization of this bipartisan legislation, which expires at the end of fiscal year 19. I thank you for the opportunity to share a bit about newborn screening. It's certainly a complex system. However, the most important takeaway is that every day, newborn screening saves or improves the lives of many children with rare diseases. I look forward to the presentation from my fellow panelists and would be happy to answer any questions at the conclusion of the program.